These spinal fluid spaces are gigantic.
Yeah.
Probably about 3 to 4 times the size they should be. And there's another one here. So your spinal fluid gets made in these big guys up in the top, and then flows down to this middle chamber here, and then goes out this little tube we call the aqueduct, and eventually it goes to your spine and turns back into blood.
Yeah.
You make spinal fluid all day, every day. You can't turn it off. And eventually get absorbed into venous blood, and like all the liquids in your body, they kind of go back and forth and turn into one another over time. But the sort of key thing here is the medical term for this is hydrocephalus, and that just means water in the brain. You got a little too much of it. The next picture here is like we're looking at you from the side. So your nose is up here, your eyes are here, and when we look right in the middle, this is where your spinal cord and your brain stem, and this is where the spinal fluid's made at the top, and then it kind of pours into this chamber. It goes down this little tube here, and right there, someone conveniently put this arrow in here for me. One of our radiologists. That's not an anatomic feature, but yeah, you don't have a mystery arrow in your brain. But this little thing here, there's kind of like a wedge there, or like a shelf, that's not supposed to be there.
It's like completely blocking.
It's a little web. It's a kind of usually like a scar tissue that forms. Now some people are born with these. Some people they develop over time. Some people are born with it and it just worsens a little bit, and you were able to tolerate it for a couple decades, and all of a sudden you can't.
So just that little
that little thing right across there.
huh?
That the spinal fluid is supposed to go like this, down through. And this is probably the kind of thing that has been like this and, slowly worsening over months to years. This is not something that happened yesterday or last week, but you've gotten to a point where it's causing enough of if you think about it like a bathtub, this is the drain, and the drain's a little bit more clogged, and that means that the fluid is overflowing a little bit more in the top of the bathtub, and at a certain point it becomes symptomatic. Now,
Can we tell if this on him was something that just started happening, or it's been there a while? Or can you...
It has almost certainly been there a while. There is no way to tell you how long.
Okay.
There's no picture that gives us that information. But when we think about, we see this disease somewhat, it's a rare disease, but a place like this where we take care of a lot of neurosurgery patients, we see a lot of it. It tends to present in younger people, and it tends to be a congenital thing. But you probably have the mildest version where it wasn't enough when you were a kid to bring you to medical attention. It took 20 years for it to get to the point where it was causing any symptoms, and we brought you here. Now, sometimes when we get these blockages, people have a tumor, and you do not. So that's the good news. You just have this weird kind of scarring.
Okay.
Now, right up here, see there's another thing that looks kind of similar, a little shelf of tissue right where that arrow is? That is a normal structure.
Okay.
That's the floor of what we call your third ventricle.
Okay.
And the best treatment for this blockage here is to poke a hole in that floor. And essentially we're making a new outflow for the spinal fluid. The medical term for that is an endoscopic third ventriculostomy.
So why is it better to poke a hole there than to just open up the
Blocked area.
That's a really good question. There are 2 reasons why. Excellent question. The first is that because you're already making scar here, if we open this back up, the chances of it recurring are relatively high. For reasons we don't necessarily understand, there's a predisposition to scar here, and that could cause trouble. The other reason is that the stuff that's on either side of this is important. So if in opening that up, we dinged something, the stuff this is part of your midbrain. So stuff under here controls some of your eye movements. Some of it controls alertness, things like that. It's not quite as bad as like vision or speech or motor function, but it's stuff that's close enough that it would only take a small amount of error for you to notice and for you to feel like you were worse off than you were beforehand. Whereas this area up here is as inert as it gets. Now obviously we're in your brain, there's always something important nearby. And when we do the procedure up here, we have to be careful. A little ways up here is some of the seeing nerves. a little ways back here is a great big vessel that does a lot of blood supply to part of your brain stem. So it's still something we have to be very cautious about. But if you were my brother and I was choosing to put a hole here, I'll put a hole here every time. The chance of something.
How much do you like your brother?
I don't have a brother.
Okay, there you
but
go.
I always wish I did.
Okay.
I have 2 little boys, and when I watch them, it makes me wish I had a brother.
Mhm.
I have sisters though. I do the same thing for them, and I like them pretty good.
Good.
Yeah, the way that we do this procedure is minimally invasive.
Mhm.
No one's shaving your hair, which is beautiful. So we want to keep
I
that.
need to wash it.
We make a tiny hole that's like straight down this way. So on your head, it would be an incision that's about 1 inch long, about here.
Okay.
We shave a tiny little patch of hair right where we make the cut, but
Yeah.
you'll cover that up easy.
It'll look like he has mange when it's not covered.
And then we drill a hole that's about the size of a nickel
Okay.
in the skull, and we pass a camera down, and the camera has a little working channel on it. We do everything using that camera.
Okay.
Procedure takes about an hour, hour and change. You're asleep for the whole thing. You come back here to the ICU afterwards for a night of observation just to make sure that you're recovering well from the procedure, and you go home the next day.
Yeah. Okay.
And then you come back and see me in the office a couple weeks later, a couple months later, just to make sure you're progressing appropriately and you haven't had any issues in your recovery.
Yeah.
But for most people, this is a curative treatment. The recurrence rate, which is to say I poke a hole here and the thing scars closed, is about 10%.
Mm-hmm.
So 90% chance this thing works and you're done.
Perfect. I'll take those.
If it closes back up, you would get the same symptoms again in the future.
Yeah.
And then what we would likely do at that point is a different kind of procedure called a shunt.
Mhm.
Now, a shunt is where we put a plastic tube in the spinal fluid spaces like this, and we implant a little valve under your skin, and then we
Yeah.
put a tiny piece of tube into your belly.
Okay.
Now, you could ask the question, why not just do the shunt up front? And there are some circumstances where we do that,
Yeah.
because it is, I don't want to say it's more definitive, but the failure rate's a little lower.
Yeah.
Rather than 10%, it's probably 2 or 3%.
Mm-hmm.
However, a shunt means you will have a foreign body implanted in your device, in your body forever.
Yeah.
And that can get infected. It's a mechanical thing, it can
Mhm.
fail. So we like to give the endoscopic treatment without the device implantation a shot first.
I like that.
And like I said, 90% of the time, that's more than enough.
Yeah.
But if it doesn't work, the plan B is a shunt. And it's the most common thing we do in neurosurgery. I do a shunt at least once a week. It's a life-saving procedure. It's extremely simple,
Mhm.
very safe. But again, if you were my brother, I would say if you don't have to have a device implanted,
Yeah.
you're 21 years old, you're gonna have that thing forever. You're better
Yeah.
off avoiding it. And then we've got that in the back pocket if you need something else down the road.
That sounds perfect. Have a backup, but
Yeah.
go for the easier first.
Exactly. The chance of a minor complication with surgery like this, which is to say an infection in your skin, a spinal fluid leak, bleeding that's bad enough that we would say we got to go take a blood clot out, but
Yeah.
that it doesn't actually cause any long-term neurologic harm to you,
Yeah.
is probably about 2 or 3%. And that's
Okay.
any time we cut anyone open. You
Mhm.
can't get around the risk of infection. You can't
Yeah.
get around the risk of spinal fluid leak. So that's always a part of the calculus.
Mm-hmm.
The chances of this getting worse and hurting you if we do nothing are almost guaranteed. You know, at some point this will turn into a life-threatening problem.
Yeah.
So that's an easy decision to make. That, you know, we have something that has a low risk and a big potential benefit.
Mm-hmm.
So it's a straightforward recommendation.
That is easy.
Because we are working near critical stuff, there's always a chance of an injury to something. You know, we do these all the time.
Mm-hmm.
It's a procedure I do a lot. I feel very confident that I can do this safely,
Mm-hmm.
but no one can make the error rate 0.
Yeah.
And the chances of something like a stroke or a neurologic injury that does harm you in some way, where you say afterwards, I'm worse off than I was beforehand,
Mm-hmm.
is probably on the order of like between 1 in 1,000 and 1 in 10,000. So rare, but not 0.
Yeah.
You know, anytime we operate on someone's brain, there's always a small chance that something catastrophic could happen. You know, we do a lot of things to try and prevent that,
Mm-hmm.
but we can't make it 0. And so it's important before we take you to surgery that we all kind of talk through these things and make sure we're on the same page about it.
Yeah. I'll take those odds. and being able to see and not having constant headaches or neck stiffness and
Yeah, and the vision, just so you understand, that is from this problem.
Yeah.
And the eye doctors looked in the back of your eyes,
Yeah.
and you have what we call papilledema, which is to say we see swelling. Your eyes, brains are so weird. Your eye is basically like a piece of brain. It's just like looking out on the world, and we can see high pressure in the brain by looking at the back of the eye, and you have that.
How neat.
And when we treat the hydrocephalus with the endoscopic ventriculosity or with a shunt, that gets better.
Okay.
And the vision should improve with time.
What
Now-
kind of time span usually?
Days to weeks.
Okay.
It's not guaranteed that it will get better, but it is guaranteed that if we do nothing, it'll get worse. And the hope is that by treating this, we will help improve that. The headaches almost always get better.
Yeah.
Some people have two reasons to have a headache.
Yeah.
Some people have just regular old headaches and also a headache from a brain problem. Vision is a very sensitive organ. And sometimes if you've had some damage to it, it can take a long time to recover. You're young, you're healthy. This is the kind of thing that usually improves. So I think the chances of your vision getting better after the procedure are relatively high, but again, it's not guaranteed. And the more important thing to do is to protect you and make sure that we don't let things get worse.
Yeah. Do you know, could that cause the neck stiffness then that I've had too? Is that kind of like all connected?
Potentially.
Okay.
That's a little bit less classic,
Uh-huh.
but you have high pressure in your head, and that can stretch out the lining of your brain, and that can oftentimes cause weird pain syndromes.
Yeah. Okay.
We thought he was having really, excessive migraines because,
Yeah.
at first it was, one a month, one a week, and then it got to be 2 a week, and then it was like every other day with throwing up, and it's been like that for about 2 or 3 weeks.
Okay.
But we were thinking into school, stress, baby on the way, all
Yeah.
that good stuff.
Yeah, congratulations, by the way. It's exciting.
Thank you.
So, because these are, it's a safe but it's a delicate procedure, it's better for you if we do it with the regular crew.
Okay.
Which is to say during business hours, not in the middle of a holiday weekend.
Yeah.
And the chances of you getting sick from this over the course of the next week or two are very low.
Yeah. Okay.
Now, I know I have OR time on Friday when I can get this done, and you're going to be with your family, and there's a medication I can give you that will slow down the production of your spinal fluid. It's called Diamox or acetazolamide. So what I think the best plan is we can let you go home on this medication. We have the imaging we need, we have a surgical plan, we've all met and talked about things.
Okay.
And then on Tuesday, when I have my scheduler and my nurse practitioner and everyone's around, we will call you and confirm all the details for time of surgery and everything. But tentatively, we'll do it on Friday.
Okay. Sounds good.
No, he had an appointment with Dr. Patel Tuesday, so we just need to cancel that then.
Which Dr. Patel is that
And
from?
Dr.
Over at
McGee.
McGee?
Mhm.
Yeah, that's fine.
Okay. So
Go to that
see
appointment or
this-
cancel the appointment.
Let me email Dr. Patel,
Okay,
and we will roll that in with the updates on Monday.
sounds super.
Because he and I talk about patients. So he's incredible. He's like the neuro-ophthalmologist who sees a lot of my patients. So when I email the team to confirm the plans for Friday, I'll just email him as well
Okay.
and say, hey, we think we found the problem and we would like to treat him on Friday. He may say, I want to see him before then, and he'll reschedule it sooner. He may say, I'll see him in follow-up, we'll reschedule for later.
Good.
So I'll ask him what he wants to do.
Okay.
Thank you.
And then
It is already scheduled for Tuesday.
This Tuesday. Yeah.
Oh, the appointment's Tuesday. I thought you said
Yeah.
Friday.
No, Tuesday.
I'm sorry.
I made it say Friday,
Oh,
but
sure. Then you go to the appointment.
Go to the appointment. Okay.
Absolutely.
Okay.
It's
Okay.
good to get the exam. It's good to have him see you. I think that's it. And I'll still email him
Mhm.
because then we're all on the same page about the plan. But yeah, we'll go because he can do a lot more of an assessment in the office
Yeah.
than we can do here. And he's going to help follow the vision long term. And if there's anything else that needs to be done,
Okay.
medication wise, etc., he can be very helpful. So yes, sorry, I didn't understand the timing. Keep the Tuesday appointment,
Okay.
but we will also call you on Tuesday to make arrangements for Friday.
Okay.
Is there a
Awesome.
medication after this that he will need to continuously take to help keep the areas open and flowing freely, or?
No, there's
Okay.
nothing that does that.
Mm-hmm.
And because of the way the pressure is high here
Mm-hmm.
and normal here,
Mm-hmm.
once we make that hole, the flow usually takes care of it itself.
Okay.
So if you have something that's open and there's flow through it, usually you're not going to make a scar.
Mm-hmm.
If the flow went really low, then you could form a scar again. And that's that 10% of people where they don't have quite high enough pressure to keep the hole open, but their pressure's just high enough that they need something,
Mm-hmm.
and eventually they get a shunt. But there isn't anything medication-wise that would be helpful like that, unfortunately.
Well, crazy question here. If he's going home,
Uh-huh.
can he play a Dungeon and Dragons tournament with his friends if he's going to
Absolutely.
get too excited?
Absolutely.
Okay, we're okay with that. All right.
With the
He had to
past-
miss it last week because of a,
No.
migraine, and so he keeps on doing all these last hurrahs before the baby gets here. So.
That's totally fine.
So he's been wearing a patch.
I
to
wouldn't
not
I
say
wouldn't
double.
do anything that's going to like really change your like mental status.
Okay.
You know, don't get crazy drunk or something like that.
Okay.
You know, you want to have like one drink with your friends. That's probably not going to cause you any harm.
Okay.
But if this were to change unexpectedly and dramatically over the course of the next week,
Yeah.
you're going to look lethargic. So what someone around you would notice is you're very sleepy, you're not waking up, people are talking to you, shaking you, saying your name, and you're not responding normally.
Yeah.
If that happens, bring them to the ER right away.
Mm-hmm.
We can do
Okay.
this as an emergency anytime.
Okay.
It's not a problem.
Mm-hmm.
But the chances of something going wrong are a little bit higher.
Mm-hmm.
You know, you're talking about 1 in 100 instead of 1 in 1,000.
Mm-hmm.
But still, if we can do it under better controlled circumstances, that's better for you.
Yeah.
You know, so we don't have to do it as an emergency. I prefer not to. But if something doesn't smell right, if he doesn't seem like himself, and in particular, if he's having a hard time alerting,
Mm-hmm.
bring him back to the ER. And don't bother, and bring him here to
Mhm.
this ER because I know him and we have a plan.
Right.
We'll get it. And there's a temporary version of a shunt where we can do it right here in the room. Just drill a hole in your head and put a tube in, and that takes 5 minutes and is immediately life-saving. So we have a lot of tools in the box we can use.
Okay.
I think the chances of us needing any of those are exceedingly low.
Yeah.
I would not let you go home if I didn't think it was safe.
Thank you.
Now, you said he could have a drink with the buddies or something like that. What about partaking in marijuana?
Again, I would avoid things where it's going to be difficult to interpret mental status.
Okay.
You know, if you're going to do a little something, either of those, I don't have a strong opposition to it.
Yeah.
I wouldn't put so much in your body that there's going to be a question, is he being weird because of drugs and alcohol, or is he
Yeah.
being weird because this has changed a little bit and we're worried about it?
Okay.
So,
Thank you.
you know,
But
use
to put your
common
family's
sense.
mind at ease, it'd probably be better just to
Yeah.
avoid.
Use your common sense. You know, I would avoid any high dose of anything.
Mm-hmm.
You know, the most conservative answer is to not do any of it.
Yeah.
But again, I'm not that much older than you. I get it. Like, you know, and I'm trying to give you a realistic answer.
I appreciate it.
If
You know,
If
the
he-
safest possible thing is none.
Mm-hmm.
But the difference between that and like one drink or, you know, one dose of whatever it is you prefer, whatever mode of delivery, is pretty low.
Okay. Thank you.
He is legal with it.
Oh yeah, no, I know.
Yeah.
I figured. I don't care. I have nothing
Yeah.
against it. And it helps a lot of people. I mean, a lot of patients use it for other reasons, you know, headaches, anxiety, all sorts of things. It's a very useful. I don't have any sort of like judgment about it. Like I think it's a good thing for some people.
And-
All I'm saying is I just want you to be in
Yeah.
a state where the people around you would notice
Yeah.
he's not himself,
There's a
and it's not because of
decline.
chemical reasons. It's because of medical reasons, and we actually need to bring him back to the hospital. I don't want
Yeah.
that to get missed because you overindulged.
so, Liv, if he gets crazy flirty, we know he's still okay.
There you go.
Yeah.
So, would you recommend me having someone around for this next week, just in case to keep an eye?
Yeah.
Okay.
You can go to sleep at night. I mean, you don't need to be like woken up and shooken every couple of hours or something. But I wouldn't go 3 days without human contact.
Okay. Okay.
You know,
okay.
I would. If someone's checking on you at least once or twice a day, that's more than enough.
Okay.
You don't need round-the-clock monitoring.
Okay. Thank
You know, you're not going to drop dead.
Yeah, because
Um,
since the last couple of weeks, it's been the same. Okay.
But yeah,
perfect.
I think that, you know, again, it's the best case scenario is to be with someone.
Yeah.
You know, be with family or friends.
Yeah.
If you're alone for a couple hours here and there, it's unlikely to be catastrophic.
Okay.
Again, the most conservative possible answer is I keep you prisoner in the hospital for a week. But, you know, I'm a person in the world, and that sounds awful. And I think that the amount of extra risk versus the benefit of being able to go home, sleep in your bed, see your family, eat stuff that's not hospital food, like that kind of outweighs the risk to me.
I appreciate that.
And the caveat is that someone will be keeping an eye on you to make sure that if something changes, you come right back.
Okay.
And if
You've got good family looking after you.
He's
You
got a
seem
lot
like
of
a
coverage.
reasonable guy. I think I can trust y'all to you know, be smart about this.
Yes. Thank
if
you.
he is,
Come in.
if he's experiencing like the neck pain or headaches, just regular Tylenol is fine to
Yes.
go through with. Okay.
Yes. And a sudden, precipitous change in your vision is another thing that I would say. You know, if you wake up tomorrow morning or the next day or something like that, and you go from I'm having some visual blurring to like, holy cow, I'm almost blind,
Thank you, Vanessa.
come back.
Holy crap.
Okay.
Yeah,
Okay.
absolutely.
We can get a table or
Definitely.
something for you.
Yeah.
Yeah,
Well,
so we're fine. We just.
Okay.
we're TV traders anyway.
Now, so like the recovery time for this procedure, and then
Great question.
also like how you feel after too. Like, is there
Yeah,
normally
really good
any
questions.
pain with it? Excuse me.
A little bit.
Okay.
A little bit. It's the spot where we make the incision will be sore for about a week.
Okay.
We will give you pain medicine to help with that.
Yeah.
Your headache could get worse for a couple of days because you're used to very high pressure right now.
Yeah.
And some people correcting from high to normal, just because your brain is accommodated to a certain abnormal state, some people get a low pressure headache from that.
Okay.
So there's a chance you might not like me very much for a week or two.
And if he gets nausea with that, is that normal too? Then?
Yes.
Okay.
The nausea now is probably from the high pressure.
Mm-hmm.
And we can give him medicine that can help with that too for the next couple days. My guess is that it's not going to. The headache sometimes gets worse. The nausea, sometimes anesthesia can make people feel very sick. Usually that clears up in a couple days.
Mm-hmm.
But those are things that we can provide medications to help with.
Okay.
You'll be in the hospital tonight.
Okay.
You'll go home the next day.
Alrighty.
You'll come back to the office and see us at 2 weeks. We'll take the staples out of your skin, make sure you're healing appropriately, make sure you're doing well, answer questions. And then usually I'll see you back again at 3 months.
Yeah.
And at 3 months, we'll get another MRI. And if everything looks good at 3 months, you kind of graduate.
Okay.
And it's just then, if the symptoms come back, obviously come see us.
Yeah.
Patel may want to see you more regularly to track the recovery in your vision.
Yeah.
That's up to him. But from a
Okay.
neurosurgery perspective, it's usually after this disease, we'll usually do visits at 2 weeks, 12 weeks, and then just as needed down the
Okay.
road. The only restriction after surgery is no heavy lifting for
Okay.
about 6 weeks.
Okay.
And that means more than like 10, 15 pounds.
Okay.
So you can do regular stuff. You can put away groceries, you can put away laundry, you can help with minor stuff around the house, you can hold a baby.
Okay.
That's
I was gonna say, hold his baby.
16th is due date, yeah.
You'll have, you know, some soreness again.
Yeah.
And it's really the first 2 weeks that are the worst.
Okay.
But as you get beyond that, if you take like a really heavy lift, like you go to CrossFit, that strain pulls in the edges of the wound.
Yeah.
And so you're not going to hurt yourself, but you increase the chances of getting an infection or having a
Okay.
healing problem. And we don't want that.
No.
So yeah, holding the baby's fine, helping with regular stuff is fine.
And so I work at OU as a tour guide on campus.
Cool.
You
You can
think?
go to work.
Okay. got it.
Excessive walking's fine, right? I mean,
Yeah, so I would probably take a week or two after surgery.
Yeah. I
And
said I can still
then-
just work back in the office and not
Yeah.
have to go out. There's the risk of falling.
Yeah, and we can write letters and things like that if you need or provide documentation that you know.
Okay.
Like this week, if you want to go to work, there's no
Yeah.
risk.
Okay.
After surgery, I would probably say you're not going to feel much like going to work for at least a week.
Okay.
You know, it's not the worst idea to take the time if you can.
Yeah. All right. Thank you.
You bet.
I appreciate you.
Yeah, of course.
Okay, so like you get a nickel-sized hole in the skull. Do you like
Does
cut
it
it
go
out
all
with a
the way
hole
through?
saw, or do you put that piece of bone back there and it goes backward.
So that's for bigger operations. We do a craniotomy, which is to say we make a window, we take that off, we put that back.
Yeah.
For that, we use something that's kind of like a jigsaw. For this, we're using more of a Dremel. So like you'd have a tiny fine burr, and you completely remove the bone from that nickel-sized hole, and then we'll put a tiny little titanium plate on top of it to cover it up afterwards. Over about a year, it fills in with bony scar. So you won't have a depression there, but the
But when
plate
he's
helps
asked
with that.
when he's asked if he has metal in his body now, the answer is yes.
The
with
answer
that
will
one?
be yes, but it's
Okay.
titanium, so
Okay.
it won't set off metal detectors at the airport, and it is MRI compatible.
Okay.
So it's a yes, but it's a medical yes.
Okay.
It's not like having shrapnel or some old hardware that wouldn't be MRI compatible. It's
Right.
there's nothing about it that would change your ability to do anything any other patient or person in the world could do.
Okay.
Awesome.
Just a little different sound when you
Yeah,
knock on
exactly.
right there.
Yeah, it'll resonate a little.
A little, yeah,
Right
more
in that
hollow.
spot. All right.
Oh, thank you so
All right.
much.
You've
Thank
been
you, sir.
wonderful.
Of course. I'm
Wonderful.
gonna give you a couple of my cards.
Really help us put our mind at ease a lot. Thank you.
Yes.
I promise you didn't make me cry. I just realized, holy crap,
There you go.
you're gonna be going in and around my brain. That hit me for a second.
Yeah, I mean, there's no such thing as a
Still
small
feeling
brain
good.
surgery, but in the spectrum of what we do, this is on the safest, most straightforward end of the spectrum.
Love to hear that.
You know, we're not clipping an aneurysm, we're taking out a tumor, putting screws in your spine. This is, I take everything very seriously. You know, I want every patient to do well, but the net risk for this is low and the net benefit is high.
Fantastic.
So just to recap, we're gonna let you go home today.
Yeah.
We're gonna give you a medication called Diamox. You'll take that every day. That
Okay.
helps with the spinal fluid production. It should help your headaches a little bit.
Okay.
We're gonna give you a medication called Zofran. You can take it whenever you need it for nausea.
Okay.
You just it's a rapid dissolve thing you put in your mouth.
Yeah.
And then Tylenol, if you need for headaches, is
Okay.
also totally fine.
Thank you.
Between now and the surgery, do not take any aspirin or anything that has aspirin in it.
Okay.
So no Excedrin or other things that have
No blood
I
thinners.
like
Yeah.
Excedrin for the migraines. Excedrin, okay.
Yeah,
I'm glad you said that.
Tylenol is okay, NSAIDs are okay. So ibuprofen, Motrin, Aleve, that stuff is all totally fine.
Okay.
But just very specifically stay away from aspirin because it's a blood thinner.
Okay.
Again, the difference in the risk is low. It's it goes from a 1 in 1,000 to a 1 in 100 risk maybe.
Yeah.
But I prefer we keep it low.
Uh-huh.
So yeah, it's
Prefer
stay away
1 in
from
1,000.
things that have aspirin in them.
Okay.
And then when we call you on Tuesday, my nurse will go over with you all the other details, like where to show up and what time and all of that.
Okay.
Because I can't access the OR schedule over
Yeah.
the weekend, I can't tell you exactly where we're going to slot things in.
Yeah.
My guess is it'll be either first thing or like late morning on
Okay.
Monday.
Sounds good.
I don't remember if we have 1 or 2 cases already scheduled that day, but we'll figure it out.
Yeah. Sounds
Okay.
good.
Are you talking this Monday or
You-
the next Monday?
So the call will be Tuesday.
Okay.
Monday we're closed.
Okay, gotcha.
And then tentatively my plan is to schedule the operation this Friday.
Mm-hmm.
It'll be within the next 2 weeks.
Mm-hmm.
That Friday I know that there's time that we should be able to use.
Mm-hmm.
The other caveat is I'm also on call all weekend. So if someone with a more serious problem comes in, we may say, hey, you mind waiting a week
Yeah.
so we can take care of them, which I know if you were the other way around, you'd want us to do that for you. But
Mhm.
Yeah.
right now, I think we should be able to get this done on Friday.
Okay.
Okay.
Super.
And again, there's also maybe someone else's operation is going to cancel on Tuesday.
Mm-hmm.
Maybe we can squeeze you in sooner in the week,
Mhm.
but I doubt that.
Yeah.
But because of the way the scheduling works, I can only kind of make back of the envelope calculations until I have the office staff here.
Right.
So go to the appointment with Patel on Tuesday. You'll get a phone call from us on Tuesday either way. And then we will make a final plan then for when we're going to do the surgery, and it's most likely going to be Friday.
Okay.
All right?
Sounds good.
Good to meet you.
Good to meet you. Thank you so much.
Meet all you folks.
Thank
Take
you.
care.
Thank you.